Welcome everyone. This is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website which is dedicated to educating you and teaching you about the human heart and its illnesses throughout the world. Once again, I thank you for your enthusiastic interest and, of course, the support that you've given me in my cause of spreading this education freely to all and bringing the awareness of the healthy human heart. Thank you again for being on MuniMeterHealth.com through our social channels. Essentially, without any further ado, I'd like to delve into the subject matter, and the matter of the subject today is cardiac tamponade. What is cardiac tamponade? And of course, we'll call it as CT here, as for abbreviations. Cardiac tamponade physiology exists when you have a pericardial effusion, which is around the heart, as you know, the fluid that accumulates around the heart, obviously pathologically. Physiologically, there's only about maximum 25 to 50 cc's of fluid, normally only for lubrication between the parietal and the visceral layer of the two pericardial sacs. But if it's anything beyond, it's considered pericardial effusion. So when the fluid accumulates to the level where the intrapericardial pressures are higher than the intracardiac pressures, cardiac tamponade exists. So remember, intrapericardial pressures are exceeding the intracardiac pressures. So intrapericardial pressures exceeding the intracardiac pressures. Now let's draw for a second what do we understand by intrapericardial pressures. So here is your heart. We are doing it in the apical view, just like what we normally draw within as we see in the echo. Now here is your echo, for instance. So the heart is represented inversely just for the sake of the students. Here is your RV and this is your RA. This is your LV and this is your LA. I'm showing the LV and LA a little more bigger and obviously more thicker in a setting because obviously it's the more powerful of the two sides. Now, when the fluid accumulates, now let's try to draw a pericardial effusion here, for instance. This will be the pericardial effusion, and the fluid accumulates rather more rapidly, which we'll talk about in a second. That fluid tends to be somewhere here outside between the visceral and the parietal layer. Remember, the visceral layer is running just right next to the myocardium here, and this being the pericardial layer. So the fluid is all around the heart, as you see, and so essentially when the intrapericardial pressures, right here, we're talking about intrapericardial pressures are right here, and intracardiac pressures are here. So when the intracardiac pressures are obviously less and the intrapericardial pressures are high, then that will lead to a compression of the RV and the RA, or the compression of the ventricles or the cardiac chambers in general. As a result, the hemodynamic compromise occurs and cardiac tamponade is present. So that physiology has to be present. What are the clinical features? Well, obviously, because of all of this that's going on, we just defined, the intracardiac pressures will be diminished, so the stroke volume will diminish, the blood pressure will diminish, the cardiac output will diminish. You will see that the RA and RV pressures will be higher. RA pressures will be higher and the RV pressures tend to be higher. And all of this is happening in the face of hypoperfusion and with an impending cardiogenic shock. So the patient may approach cardiogenic shock. And because the RA and RV pressures are high, so the JVD will be high. Jugular venous pulse will be high, or the pulse pressure will be high, and therefore the jugular venous distension will be present. IVC will be distended as well. In fact, if you were to look at the IVC here, because remember IVC and SVC, they are pouring into the right atrium. They're bringing blood from the lower extremities in the case of IVC and upper extremities, and obviously your head and neck area from the SVC. So these will be distended, specifically the IVC, and they will not show any respiratory variations, which we'll get into a second. So all of these signs will suggest that hemodynamic compromise has occurred as a result of increased pericardial fluid that has accumulated rather quickly. So it's a more acute onset of fluid accumulation that results into a tamponade. Now, there's a caveat. You may have a huge pericardial effusion, a bigger effusion, but may not show signs of cardiac tamponade. Why? Because it took several months to develop, and as a result, the pericardial sac is a little more lax at that time over the several weeks and months that has grown in that size and has accumulated and does not reflect the intrapericardial pressures to be elevated to suppress the intracardiac pressures, if you will. So so let's understand what the physiology is. Obviously, the intrapericardial pressures, as I said, have to be higher than the intracardiac pressures, number one. The rate of fluid accumulation has to be very rapid. So rate of fluid accumulation has to be rapid. And three, very importantly, you should have RA, the RA which is considered as thin. Now remember, the RA is thinner than the RV, is more thinner than the RV wall. So RA collapse will occur. As a result, what happens is each time the intracardiac pressures here, for instance, drop below the intrapericardial pressures during the cardiac cycle, immediately all of this will compress the RA like this. So that's called a collapse. So the RA will collapse during systole, and an RA collapse in systole more than 1/3 of the period of the systole. That is considered as a very specific and sensitive sign for cardiac tamponade. One will also see an RV collapse. So which will start collapsing first? Obviously RA, because that's thinner wall. So anything that's not producing enough resistance will collapse first in the presence of high pressures. We know that. So RA pressures being lesser, one, and two, a thin wall, that'll collapse first and in the earlier part of the tamponades. And as the tamponade is progressing and that the intrapericardial pressures are rising, they will start to even collapse the RV, if you will. So the RV will start to collapse. Now, once the RV starts collapsing, that of course occurs during when will the RV collapse? RV normally has a systole. So the RV is having a systolic time when it's actually ejecting. But when it starts dilating, that's when the pressures are low, and immediately that'll collapse. So RV collapse during diastole. Please note. So RV collapses during diastole, RA collapses during systole, and all these are very sensitive and specific signs on echocardiography, best seen on a 4-chamber apical view, sometimes even in a subcostal view. So you can see a subcostal view, or you can see in a 4-chamber apical views. And these are very, very important views in the echocardiography. Now, echocardiography, if you do not see a pericardial effusion, tamponade is ruled out, because you have to have an effusion to begin with to cause it a tamponade, remember. So echocardiography is very, very diagnostic, plus it's also very good to exclude if your suspicion was based on the findings that the blood pressure is low, the JVD is high, and the cardiac output is low. They're all signs of hypoperfusion. And we don't know whether the patient has pericardial effusion. Now you take the patient for an echo and you do not see any effusion. Cardiac tamponade is pretty much ruled out. Start concentrating on something else. That means your diagnosis is incorrect. So remember, you have to demonstrate an effusion in order to see cardiac tamponade physiology. And intrapericardial pressures have to be higher than the intracardiac pressures during the changing pressure cycles of the cardiac cycle. And as a result, the RA pressures will RA collapse, the free wall of the RV, this is the free wall, that'll collapse earlier than the RV as the tamponade progresses. Okay, different phases of tamponade, you'll see RA collapsing earlier, then RV collapsing later, and then both will be collapsing together or whatever. So you will see both in the similar. Now, a very important finding also that you'll come across during the echo is also that there is an increased respiratory variations. Now, each time the person takes a deep inspiration, etc., or even doesn't have to take a deep inspiration, even normal breathing cycles, the tricuspid flow, which is right here, and the mitral flow, which is right here. Let me just bring down that diagram again, because you have the mitral flows here, that's going through here, and then the tricuspid flow here. The tricuspid flow will be increased, and the mitral flow will also impact during expiration or inspiration, and those impacts will be increased. Increased respiratory variation, we call it. across the tricuspid valve and the mitral valve flow, if you will. So that's where we are with that. So these are some of the various important science and diagnostic features on an echocardiography. Now, what is the etiology of pericardial effusion? Obviously, the etiology of pericardial effusion is, it could be bacterial infections, very important. Viral infections are very important. Tuberculosis, do not forget that. Malignancy, do not forget that. Thyroid, obviously hypothyroid can result into then connective tissue disorders like SLE, RA, and those things must be, so you have to order those ANA testings, what have you, in order to make sure that you have tested for all etiologies. Renal failure obviously has high amount of fluid collection around the heart, and that can lead to tamponade. So, but remember, one of the things for cardiac tamponade is you may have large fluid collection. Again, repeat that sentence that I said earlier. You may have large pericardial effusions, but may not have tamponade. All you take is only 150 cc's of fluids, I'm just giving you an example, to accumulate to cause tamponade, whereas 400, 500 cc, even liters of fluid have been accumulated in the setting of, say, tuberculosis or mixed edema or hypothyroidism people have seen, or tuberculosis specifically, even malignant effusions. They could be large effusions but may not show signs and physiology of tamponade. So tamponade itself is a very, very important clinical entity, and that should be. Now, how do you treat all of this? Well, the first thing you want to do is relieve the intracardial pressures. And how would intrapericardial pressures? How would you do that? Well, echo-guided pericardiocentesis. So that's the best way to, again, remember it's an invasive technique, so you have to put on a needle, mostly from the subcostal, because that's where the most fluid is accumulated in the dependent portion of your heart. So having said that, the echo-guided pericardiocentesis is the way to go. Now you can do a surgical pericardiocentesis as well, bring the patient to the OR, and you can do a surgical pericardiocentesis there as well. So, but echo-guided pericardiocentesis is the way to go, because you really need to improve the cardiac output, the hypoperfusion, etc. Very important finding. Remember, just like if the person is taking let's understand what happens with the respiratory variation, for instance, before we delve into anything else. Respiratory variation leads to a condition called pulsus paradoxus. Remember, now pulsus paradoxus, as the name suggests, it is not paradoxical, by the way. There is no paradox here. It's a misnomer. So I call it a misnomer. Why? Now, these are some of the misnomers in medicine, and this is one of them, and I'll tell you more as we go along, but this is a misnomer. Why? Because, let's understand, in normal respiratory cycle, during inspiration, when you take an inspiration, what happens to your venous return? The venous return increases, the RA and RV pressures will increase, but the left ventricular output, the stroke volume, will decrease. So what will happen is your blood pressure actually drops and your heart rate may increase. Now, the blood pressure drops, or systolic blood pressure that drops, it should not drop beyond 10 millimeters. So it's less than 10 millimeters only, which is considered as normal. Where's my screen here? Which is considered as normal. And essentially what you're looking at is when you have more than 10 millimeters. Now, some texts will define 20 millimeters, but anything more than 10 millimeters by definition is considered as pulsus paradoxus. So more than 10 millimeters drop is considered as pulsus paradoxus here. So pardon me if my screen moves a little bit because of my pen being a little more sensitive to that level. Okay, good. So pulsus paradoxus, now we understood the physiology why it occurs. So as simple as that, let's understand how that happens. Here's the heart. Here I'm drawing it normally like it sits in your chest. I'm not drawing it like in the echo. So as the now you have pericardial effusion, which is sitting outside. Obviously, this is all effusion here. This is all effusion I'm drawing quickly. And the RA pressures, what will happen is if this is in your chest and this becomes your chest. So the intrathoracic, now here's another thing. Intrathoracic pressures fall during inspiration. So as the intrathoracic pressures fall during inspiration, air is sucked in. That's how lungs get the air. So the lungs get the air primarily because the intrathoracic, you take a deep breath and you'll find that actually what you've created is an intrathoracic pressure drop. So the air sucks in by vacuum or whatever. So when that sucks in, what will happen is intrapericardial pressures will also drop because the intrathoracic pressures are relieved. Intrapericardial pressures will drop, so the pericardium is less tense. Now what will happen is intrapericardial pressures drop. What will happen to the intracardiac pressures? The intracardiac pressures, which are already elevated to begin with, now all of a sudden they will rush more blood into the RA and RV. So you have increased RA and RV return. RA and RV return increases in inspiration. Very important. If that increases in inspiration, what happens to the septum? The septum guy is here. That starts to move into the LV cavity. It moves into the LV cavity, so the LV cavity actually becomes smaller. So LV volume will diminish, and as a result, the stroke volume will diminish, and as a result, the cardiac output will diminish. So I know there's a huge physiology about pulsus paradoxus, which I want to do separately into another video. It's beyond the scope of the time here, but just so that you know, intracardiac pressures have to be lesser than the intrapericardial pressures, and if you can demonstrate that, cardiac tamponade physiology exists. Whether you demonstrate by echocardiography means or actual pressure, which you could measure by pericardicentesis if you attach a catheter there and measure it with the manometer. So these are some of the things. But again, as we discussed, the etiology is bacterial, malignancy, thyroid, renal failure, and connective tissue disorders, and of course many times it's idiopathic. Traumatic dissection, aortic dissection also leads to a rather sudden tamponade in a setting, and that has to be recognized rather quickly, otherwise mortality is extremely, almost close to 100%. Now, sometimes cardiac tamponade will also lead one to develop pulse, it's called pulseless electrical activity, remember that? And that's again, it's a, you try to resuscitate the patient by giving positive IV fluids, inotropes, and of course pericardiocentesis in that setting. So pulseless electrical activity is also a cause of cardiac tamponade, or cardiac tamponade causes it rather. So just remember that exists with that. And the treatment plan, as I said, is clearly related to pericardiocentesis, sometimes surgical drainage, but do institute IV fluids to resuscitate. So IV fluid resuscitation is in place because you really want to keep the tanks full. You can't give diuretics in this setting because that'll really tank this patient totally out. So just make sure the patient is nicely fluidly resuscitated. And also you may want to use pressors like dobutamine. Now, one caveat here, just remember, do not, if you can avoid intubating this patient, do not use PEEP, P-E-E-P, as we talk about, in a setting of cardiac tamponade as much as possible. So mechanical ventilation should not be used because that's going to increase the intrathoracic pressures, and as a result, the whole physiology will only worsen and the left ventricular output will be even further diminished. So you want to try and see how best you can actually keep the patients ventilated on their own by increased oxygenation, etc. But try not to give the mechanical ventilation. Mechanical ventilation should be avoided, remember that. And PEEP should be avoided. So both should be avoided, mechanical ventilation and PEEP should be avoided. So having discussed all of this in this short video, I know it's somewhat a little beyond time, but it's a very intricate subject, as I said. Hope the residents, the fellows, the medical students, and of course my colleagues and attendings, they enjoyed this discussion. And again, go for the boards and don't fail the test now on cardiac tamponade and pulsus paradoxus and the echocardiographic features. I rely on you, I depend on you, and show me your medal on this. Thank you so much for associating with MuniMeterHealth.com. I love you guys and see you again on my next video. Thanks. Bye.